Yeah, ma'am.
Yeah, thank you.
Thank you, sir. Thank you so much, sir.
Thank you, Dr.
Thanks,
Nirmal
ma'am.
Kumar, Mr.
Thanks,
Nirmal
thanks so
Kumar.
much.
I now request.
You can, Nirmal Kumar, you can play this video later on because we are not
Sure,
able
sure.
to hear the sound. Okay, we'll start with the
Okay, sure.
program. Okay,
Thank you, sir. Thank you so much.
Dr.
Sir.
Bharati Rajshekar can take over.
Yes, thank you, sir.
Praveen, Arun.
Namaste to everybody. I now request Arun to kindly start the meeting with the invocation to the Almighty.
Good evening. Kindly mute yourself.
त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
After invoking the blessings of the Almighty, and I wish everybody a happy Mahavir Jayanti, a happy Ambedkar Jayanti, and a happy Tamil New Year Day, and a happy Vishu to all those celebrating this auspicious day. And I now request our President, Dr. Kasturi Donimat, to give the welcome the gathering for this KSOGA KCOG webinar. Dr. Kasturi, madam.
Yeah. Good evening, everyone. My video and audio both are visible.
No, madam, your video is not visible. You're not visible.
Okay. Audio, am I audible?
We can hear you.
Yes.
You're audible. You're audible.
audible.
Suddenly something happened to the video. If it's visible, suddenly I don't know.
You're audible.
Technical problem. Okay. Good evening, everyone. Namaskara to everyone. And happy Ambedkar Jayanti. Happy to all. And Mahavir Jayanti. And today is our second program of Kasoga KCOG program after I took over as a president. Feel very proud to be carry on these programs. This is the first state organization to start KCOG in all the Foxy societies. And these KCOG programs are very well, very famous. Most of the delegates are waiting for these KCOG programs, especially the CPAP and the skill transfer programs. So people keep asking me, when is the next KCOG skill transfer program and who is the speaker? So this is really a most opted program. People are looking for this Thursday to join for this program. And for this initiation, I thank our Chief Patron, Dr. M.J. Ramat sir, Patron Dr. Nagaraj, Dean Dr. Hema Devakar madam, Chairman Dr. Muralidhar Pai sir, Vice Chairman Dr. Sajjan sir, and Secretary Dr. Vidya Bhatt. And all the Kasoga EC members, Dr. Bharti, again Secretary of Kasoga, and Dr. Durga Das, Treasurer. Thank you for starting this initiation. We'll continue these Kasoga KCOG programs throughout the year. And today just I was discussing with Dr. Muralidhar Pai sir to start PG teaching programs at least once a month on Saturday, Sunday as a part of Kasoga KCOG. So we are thinking of more newer initiatives as a part of Kasoga KCOG programs. And today for this Kasoga skill transfer program, we have a very eminent faculty, a very great speaker, a great orator, sir, a teacher of teachers, whom I always admire. He's a great inspiration to me. I look up to sir, not just today, since last 30 years. He's my teacher also. And I actually follow all his lectures, which he has given over the years, his blog and his mails. Sir, thank you for transferring skill, not just today, in years together you have transferred. Your knowledge transfer has made a difference in our practice. I follow your so many things, especially the recurrent pregnancy laws and other topics, and we transfer in turn to our students. So you are a real teacher of teachers, sir. And your today's talk is very, very relevant. Near-death situations, analyzing and training, very, very important in the current scenario. As we all know, our maternal mortality has decreased compared to the past, and especially Karnataka is now 83 per lakh. But still, we always think, even though it is less compared to the northern states, if you take the southern states, still our Karnataka is higher compared to Kerala, Tamil Nadu, and Andhra Pradesh. So our now important aim is to reduce the deaths furthermore and bring it to single digits. So for this, your knowledge transfer, your knowledge from your vast experience of almost more than 35-40 years, very important. We are looking forward for the golden words from you, sir, the golden pearls, and your knowledge. We are going to take it forward. We are going to take it back to our practice, in our day-to-day practice. And sure, we promise you that with your knowledge, which we implement in our day-to-day practice, will sure save some lives, sir. Thank you for joining us as a guest speaker, and looking forward for your pearl of wisdom, sir. Thank you once again. Thank you one and all for joining this program. Thank you.
Thank you, Madam President, Dr. Kasturi Donimat, for that warm welcome to the audience. I now request our Chief Patron, one of the pillars of Kasoga, and whose dream child, I think this project of KCOG skill transfer is there. I request Dr. M.G. Hiramat to kindly say a few words.
Good evening to everybody. Once again, welcome you, sir. Dr. Pankaj Desai, sir. I know you for last 30 years, and we have worked together in many of the Foxy projects. You are one of the luminaries of Foxy, and you are a great teacher. So we were discussing last month only, myself and Vidya, let us whom to invite for the next program. Unfortunately, we are already engaged in a different program, and you gave us well in advance that I will be there on the next month. And subject also we were discussing. And during the discussion, I think you have told that this is one topic which is very, very important. And it is very true, because the near-death situations are the one which are to be sorted out. As you know, that maternal mortality rate of our country is quite high when compared to others. Though we have done something, but not enough to be satisfied. Particularly our own Karnataka state, where we have got the maternal mortality is quite high. And this concept of near-death situations came in the last 10 to 15 years. Earlier, it was not there. Earlier, only used to say that maternal mortality, then have a small discussion and close it. But effective analysis, probably in our Karnataka, started from Kerala, Dr. Bailey, and went on to all the states, and every state medical colleges have started. In fact, when I was the HOD of OBG in our own KIMS college, we started in the department every month analyzing every maternal death. And we started an HDU, and we started an high dependency unit. And we found a lot of difference in the mortality, and not only in the mortality, the morbidity rate did come very, very narrow. I think with this knowledge, definitely everybody can see forward of reducing the maternal mortality and morbidity. And sir, this our KCOG started 1 year back, and we are conducting regularly programs 4 days in a month. Every Thursdays, first Thursday CPAP. Our convener is Dr. Muralidhar Pai, who is the chairman of KCOG. Second program is Dr. Vidya Bhatt, who is the secretary. We have named it as skill transfer. We are inviting the speakers who have some skills which is needed to be transferred to others. And third is our national program, where we are inviting the Foxy leaders as a speaker. And Dr. Hema Divakar, our dean, makes every attempt to get every time. Not even a single month she has missed the program. And every time we had excellent speakers from national, international. And we were, in fact, we are sorry that we took a lot of time to invite you. I think ultimately it has happened. And as you said that you are so close to Karnataka, definitely we feel you are our own person. And just everybody is waiting. Already 71 have logged in. By the time we start the program, we will reach to 100. and you can take your time and please go ahead with your program, sir. Bharati.
Yes, sir. Thank you, sir. And I would like to express the inability of our Dean, Dr. Hema Divakar, inability to attend this meeting due to other work on her hands. I now request our immediate past president, Dr. Basuraj Sajjan, to say a brief message to the audience.
ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರಗಳು. On behalf of Kasoga and KCOZ, where I am in the Kasoga as a past president and KCOZ as a vice chairman, this academic wing, it is a second year. They are doing a very excellent skill transfer programs. So today we are very lucky and opportunistic to have a Dr. Pankaj Desai as a writer and a great teacher. We are having opportunity to hear his lecture. And it is all done by our Kasoga Chief Patron, Dr. M.G. Remat, for the academic wing and this Kasoga team, and all Vidya Bhatt and Hema Divakar Madam, Muralidhar Pai, Doni Mat, very interested and very dynamic, teaching everything as a HOD, and she's interested in academic work. Durga Das and whole team is supporting this program. We wish that the same thing what it has been continued in my period, the same thing or more than that, it will be going to conduct with the eminent teachers with many more programs. Thank you very much for giving me an opportunity to share my ideas. Thank you very much for my opportunity.
Thank
you very much. Thank you.
Thank you, Dr. Basuraj Sajjan, sir. And we promise that we will carry forth the torch that you have lit to illuminate many more minds by great teachers like Dr. Pankaj Desai. I now request our chairman of the KCOG, Dr. Muralidhar Pai, to give a few remarks because he has another meeting to attend and he has to leave shortly after Dr. Pankaj Desai's lecture. I request Dr. Muralidhar Pai to address the gathering.
I think he is not seen.
I know he said he had some college meeting. I think
Probably,
he's already left, probably. Maybe he will join us again. So without wasting much time, I request our Secretary KCOG, another exponent of academic excellence, Dr. Vidya Bhatt, to kindly introduce the star of the evening, Dr. Pankaj Desai, to the audience.
Thank you, Bharati Madam, for the kind words, and it's my proud privilege to invite Dr. Pankaj Desai, the eminent speaker. Arun, please unmute the others.
Please mute the others.
Mute the others, please, Arun. Yeah, sorry about that. So it's my proud privilege, sir, to invite you for this KCOG skill program. And as a fan of yours, I'll put it like that. I have been following all your lectures. I think I first remember the first lecture which I heard of you of IUGR. It is still, the points are in my mind. And the BSOG CME you spoke on previous LSCS. Whenever you are on stage, you illuminate the stage, you set the stage on fire, and every student is so alert listening to you. It is my joy to talk about your achievements, the positions held. Of course, past Foxy president, we all know about it. Then look at your academic excellence. I don't think many have this kind of academic excellence with gold medals, with awards, and then with publications. And then you're a visiting professor to Liverpool Hospital, Sydney. So we are so proud of you, an Indian being a visiting professor. That's really a great achievement. And then you have reviewed so many articles and you've written textbooks. And also you've been the president of Gujarat, All Gujarat Society, and the president of Baroda Society, and Foxy Medical Disorders Committee chairperson long back when I was a postgraduate student, and I've heard you since then. I've been following you in the sense I'm a fan of yours, following all your blogs, all your teachings, and anything you say, it has so much of evidence. And today's topic, especially in this era where doctors are beaten up and we have had so much violence against doctors, this topic is apt because we do face the situation in our life. So analyze
Others, please mute yourselves.
Problem is a major challenge to everybody. And today's topic is really popular. I mean, people want to know about it because You can see all the illuminaries of Karnataka have joined this program. So we are sure we are going to get really those tips and tricks to handle these situations and learn from what has happened. So thank you for this opportunity, sir. And over to you. And we look forward for the great learning, which we are always learning from you.
Thank you, Dr. Vidya. But I think Dr. Pankaj Desai will never require an air conditioner because he has so many fans around him.
Yeah.
Over to you, sir.
Big mind. I'm the biggest.
Yes, and me too. Over to you, sir.
Bharti?
Yes, yes, I told him, Arun.
Arun.
Adi yara unmute madappa adi yarno. Who is that person?
Can you see the screen?
Yes, sir.
Yeah, yeah.
Okay.
Yes, sir.
Okay. As usual, we will start with a prayer. May all those who are afflicted be affliction free. May they be serene through all their ills. Even if bodily afflictions do not subside, may we all be healed in heart and mind. Honorable Dr. Hiremat, Dr. Bharati, Dr. Vidya Bhatt, Dr. Amrish, Dr. Sajjan, Dr. Kasturi, Dr. Durga Das. I remember you all. I am not away from you. Last week at Indore, Pratap met me and he said that you are so close to us in my heart. I felt that in fact he has honored me in the entire Karnataka. And when you said that Karnataka is close to my heart, my daughter lives in Bangalore.
Okay.
And my two children, my son and daughter-in-law, are soon going to go there. They are holding top positions somewhere. I don't want to, they are not in OBGYN, but they are holding top positions in IT companies at different places. It is possible that after I retire, I might even come repeatedly to Bangalore and
Welcome,
Karnataka
sir.
becomes
Welcome.
mine.
Welcome.
What man decides, I don't know, but I'm today really overwhelmed. Such wonderful people and so much desire to learn, so much desire to know. And then when you said that skill transfer, it is a duty on teachers like me. And that I have taken it very seriously. I have seen you people, your commitment at PG programs which I used to come and address in Bangalore. Yes. And that was the time when Hema and all were still nowhere on the horizon. But still you people were there and Hema was just coming up. And what impressed me was that so much desire to know, and today Dr. Hiremat corroborated it. And very silently you people are working on me, and I will tell you why. On my website, www.drpankajadesai.com, you can copy everything, every slide, every lecture, everything, and you don't acknowledge me. Nowhere you will find my name written in small words anywhere. Take it, because my name, because I am not immortal. These ideas without my name become immortal, and they go somewhere and they help. Today, somebody quotes, some teacher said, it might be Hiremat who might have said, some teacher said, maybe Hema might have said, someone taught us, maybe Sajjan sir might have said. We really don't know, but these ideas are immortal. So therefore, right from first, and therefore, and I openly admit that Bangalore OG Society postgraduate programs made me do this. No copyright or nothing on my website. It's a free website. You can go and copy everything, and that is skill transfer. Skill transfer, what a concept, what a noble concept you people have developed. It should not confine to this 1 hour. It should be eternal. What did we come with? What are we going to take away with? These are the things which are going to remain and going to touch humanity and mankind. The recording of this lecture is available. Sorry. Yes. The recording of this lecture is available on my YouTube channel. There are nearly 30,000 views to this. You can go, his name is Simple Pankaj Desai. Text of this lecture is already available. I have uploaded it on drpankajdsai.com, and you can please, all of you, you can mail me at any time. I will surely reply, not immediately, but as soon as possible, I will reply. Now, a very pertinent question. Why do you require me when there is Google? Okay, you have everything. Near miss situations, go to Google, you will find it. Everything is there on Google. Recently, tomorrow being Bengali New Year Day, I asked one of my Bengali friends that is it tomorrow or today? And before she could reply, I Googled it and I got the answer that Poila Boishak is tomorrow. So, but why do you require a teacher now? What is its relevance? The relevance of the teacher is Google cannot give you creativity. Creativity is yours. Critical thinking doesn't come from Google. Google only transmits information. Even AI doesn't give you critical thinking. My daughter-in-law is AI boss, who has given me an extra light today. She is AI. She's a master in AI. Still, no. And you cannot develop collaboration because Google says so. And it sharpens your communication skills. And therefore, you require a teacher to come here and teach and postpone and suspend his consulting hours, which are actually going on right now downstairs, because we live in the same complex. Ground floor, first floor is the hospital, and second floor is my residence. This is my actually study room. Sometimes I may get tired while reading, so I sleep behind. You can see the bed here. I have a small invite you song of 30 seconds. Let us go. Today the challenge on me was I have to balance between theoretical knowledge and practical knowledge, and that I am going to do. I have worked hard since Vidya told me 1 month before I have started working on this presentation, and she gave a very nice topic. Of course, you people decided it. Near-death situations, analyzing and learning. I will be bringing situations, we'll analyze and learn therefrom. But a small theoretical introduction here, and that is, let me introduce you to what is maternal near miss. A maternal near miss is defined by WHO as a woman who nearly died but survived a complication that occurred during pregnancy or childbirth or within 42 days of termination of pregnancy. Fine, this is for the postgraduate students. But for us, the incidence of near miss events is 31.4. Wait now, the incidence of maternal mortality is 8.2. So the ratio of near miss to maternal mortality is nearly 4.1. 3.8 is to 1 to be accurate. That means if Karnataka has a maternal mortality today of 80, his near miss is 320. Okay, so please, it is nearly 4 times. With this in mind, that will give you the idea of the importance of this topic, and we will see the first tricky clinical situation. Let us unravel it. An unbooked patient underwent emergency LSCS for previous 2 LSCS at a district hospital. Common picture. Intraoperatively, placenta accreta was diagnosed. This is very dangerous. Nowadays, it is becoming common, very scary. Intraoperative diagnosis is very scary. Due to hemorrhage, a subtotal hysterectomy was performed. 4 units of PEG cell transfusion were given, but the patient continued to have bleed. Hence, she was transferred with 4 more units of packed cells to a bigger institution, to the medical college probably. On receiving the patient, she had a pulse of 160, BP not recordable, and extremities were cold. So now this is near miss, or we may miss her. And that is required. What is required is quick decision making. On examination, abdomen was soft. Vaginal bleeding was present. 8 units of FFP, 4 units of platelets, and 4 more packed cell units were given. See, this is what it can mean. Concurrently, the patient was taken up for emergency laparotomy. And what they did, they removed the cervix with internal iliac ligation. Now, is that okay? Yes, you might like to think, is it okay or did she survive? Well, time will tell, and I will tell you, I am introducing you here to a word of consequentialism. This word comes from a Greek philosopher, Demosthenes. Demosthenes believed that to validate your decision, you have to see the consequences. And if your consequences are proper, your decision was valid. Let us see what happened here. Post-operatively, pulse was 140. BP was 90 systolic. Means, yes, this was a good decision. Patient was given ventilatory support for 12 hours and then extubated. Patient was well and was discharged on the 10th post-operative day. But what was the lesson learned? What do you analyze and what do you get? If possible, primary surgery should be complete. Then this near miss could have been a little mitigated. I don't say placenta accreta near miss, you are on a volcano. But if possible, primary surgery should be complete. The quick decision making and decisive action as was done here, that while the blood was being pushed in, the surgery was also started and a competent surgeon took over the case. I'm sure the team, the full team, and they did a right surgery and a complete vigorous treatment. And very important, seek help. I'm coming to this help a little later, but seeking help is very vital in near miss situations. We now come to the next tricky clinical situation. A 26 years old G1 P1 was referred from a peripheral hospital to a teaching hospital. Had persistent bearing down efforts after a spontaneous vaginal delivery. After a vaginal delivery, she did not have twins. Live neonate of birth weight 3.4 kilograms was 6 hours prior to the presentation at hospital, and still she was bearing down. Now what is happening? This became a potentially life-threatening condition. On examination, a young lady was found who was pale and dehydrated and intermittently straining in response to the irresistible urge to push. Her pulse was 102, regular moderate, blood pressure 120/70. Uterus was about 20 weeks pregnancy size, well contracted, and she was continuously feeling an urge to bear down. Think over what we found on examination. It was actually a blood-smeared vulva with a tender swelling involving the right labia minus and majus both, measuring about 4 by 4 centimeters. You can see it here. Such a big hematoma has collected. Now, this seems to be okay for people like very experienced people like Dr. Hiremat or even Bharati, knowing her for so many years, Basavaraj sir. Okay, this we can handle. But no, soon she collapsed. With tachycardia increased and hypotension got precipitated. Quickly catheterized and anesthetized. And you can see the picture here. Now you can see the swelling. The vulvovaginal hematoma you can see here with the urethral catheter in situ. Hematoma was drained. Hemostasis was achieved with figure of 8 sutures. The space was obliterated with deep sutures and the overlying skin approximated carefully, avoiding injury to the urethra. The vagina was packed to further assist with hemostasis. This was the picture after suturing. Now you will feel that what is near miss in this? Why did she collapse? My question here is, anything else needs to be done? Or is it over? There is a hidden danger there. And what is the hidden danger? You must do a clinical examination and ultrasound to rule out an internal extension above the levator. If you can go above the hematoma, then it is fine. But if you cannot go above the hematoma, the swelling, that means there is an extension in the extraperitoneal space, and be prepared. This may require ligation of the vessel as well as internal iliac ligation. So this is the message of this case. She had broad spectrum antibiotics, transfusion of 3 units of blood, and discharge on the 3rd day following a satisfactory recovery. I will be coming to one more case where a complete reverse has to be done. Completely paradoxical. I will come to that soon. Now we come to managing the crisis. We have seen the 2 cases. Now we come to managing the crisis. Now I am giving you a situation to think for. There are 2 patients who deliver in quick succession at your hospital vaginally. Both are having TPH. Now, which of these you will shift to the ICU? Meaning, which of these is close to near miss or in a miss? So, shifting to ICU, you will say both. But that is not the skill. The skill is to identify which one to shift. Important signs of serious injury where you would like to shift: low blood pressure or weak pulse, cold extremities and peripheral cyanosis. And other warning signs requiring critical care: reduced urinary output, dyspnea or hyperapnea, high temperature, cold extremities, high temperature, bad combination, very bad combination, and unexplained fatigue, as well as chest pain. Any one of these is dangerous. One more, tachycardia and palpitations. Now, these are quite objective, but do we have something strong, something objective to rely upon, as strong as the biceps of this lady? Yes, we have. We have something objective, and that is shock index. Shock index is heart rate divided by systolic blood pressure. SI is equal to HR divided by systolic blood pressure. I will give you a proper example so that you can employ it. Many of you might be knowing it already. A marker that can be used to predict the severity of hypovolemic shock. In most studies, it has been found to be a valuable tool, and it can raise suspicion even if the heart rate or blood pressure are apparently normal. It can be, and I will come to that soon. When can it be? The accepted value of shock index ranges 0.5 to 0.7. I am going to take this presentation. I have already taken and will be taking in an edited form again on my YouTube channel. You can go and copy it there. I have no problems. The shock index greater than 1.1 is abnormal. Now let me give you an example. In a very calm situation, she has just delivered, heart rate is 70, systolic blood pressure is 120. Now, HR divided by SBP will come to 0.58. Now, 0.58 is normal. So, it is an accepted value. Shock index does not want her to be shifted to the ICU. But our heart rate is 120. Systolic blood pressure is 70. Means you know the shock is coming. Our shock index is 1.7. Beyond 1.1, and that is abnormal, please shift up. I will give you an example now, last one, where HR is still 80, because we know the sympathetic parasympathetic overplay. HR is still 80, but the systolic blood pressure has fallen to 60. Now, this is where the shock index will come to 1.3. So, even if you are in the full paradise of 80 heart rate, shock index is 1.7, shift. This requires extra help. So this is where the practical value of a theoretical knowledge comes in. A management of near miss. And I'm giving you a situation now As you can see here, I was giving a trial of labor to previous LSCS car attempting a vaginal birth delivery. Labor did not progress and the patient's general condition worsened. I knew this is a rupture. I rushed inside and I opened up and I found what I had expected. First, I tried to save the uterus, but failed. So I did a hysterectomy. Everything okay. It seemed like shifted the patient to the ward. As the surgery was prolonged, I had a big backlog at the outdoor. The ward paramedic staff was providing me with all the info on vital parameters on my phone call continuously. All seemed to be going well. Suddenly the patient collapsed. It must make you think what must have happened. Everything was okay. What must have happened? Let me tell you. After massive hemorrhage, meticulous monitoring of my patient's pulse and blood pressure is mandatory. Recognizing shock in early stage may be missed. Otherwise, on especially busy days, this has got an inflammatory reaction there. Prolonged surgery or surgery following massive hemorrhage can send the patient into shock, even at a little later. After a hemorrhagic shock has been tackled, the obstetrician should continue to be vigilant even after the vital parameters begin to improve. Oh, everything is fine, because there is a systemic inflammatory response. And we have seen in corona days what inflammatory response suddenly does. And we have lost our colleagues. So many. I have lost 2 of my students. I have lost my teacher. I have lost 2 of my colleagues, my very own. All of them were in my son's marriage just 1 month before. And all of these I have lost. Suddenly, all improving and suddenly lost. This is the inflammatory response. So the near miss situation does not stop for quite some time till that the problem is over. Therefore, near miss. We now come to the crisis management. And here, I observed 2 paradoxical situations at times. In spite of excessive bleeding, many times blood pressure remains fine. And I have seen many practitioners. Sir, bleeding is more. Blood pressure is fine. You can come a little later. We will see when help is asked for. I always say, I'm coming. I'm coming. And sometimes in spite of clinical volume correction, BP doesn't respond fast enough. Why this happens? Now, in spite of excessive bleeding, many times BP is just fine. Fall in arterial pressure during shock states may be delayed because her compensatory phenomena mechanisms are robust. Therefore, the fall is getting delayed. Severely reduced cardiac output for periods of 40 minutes to 2 hours can occur before a significant reduction in arterial pressure occurs. So therefore, don't waste time. She is sinking, rush. And in spite of clinical volume correction, blood pressure doesn't respond fast enough. Why does this happen? If fluids are used to restore blood pressure, the cardiac output and oxygen transport may still need to be corrected. Only the fluid has been replaced. The cardiac output is still not corrected. So the blood pressure will take a little time. That is the time when I have been called to help. I always tell, don't worry, beta, it will come around. I am sitting here, don't worry, I'm not going home. Because they feel that now Sir has done the surgery. And never in a crisis I charge, never. I sit there, I tell them, I will sit there, beta, here. Don't worry, even if it is 12 o'clock, 1 o'clock, I'll sit there for 2 to 3 hours and then I go home. This is the reason. We now come to the next point in crisis management, which is important. I'm not going to give you an idea of what an undergraduate is given or a postgraduate lecture is given. No, I am coming you straight with a clinical orientation because I know that there are amongst the 90 plus people sitting here, most of you are practitioners. And I'm bringing a paradoxical situation. Which came first, the egg or the hen? Many times we ask this question. What is a paradox? A paradox is a paradox that baffles and confuses and is a statement that seemingly contradicts itself. I will give you one statement. On one side, there is vasoconstriction. On the other side, there is edema. On one side, there is hypertension. Other side, there is shock. On one side, everyone seems to be knowing the management. And the other side, nobody knows. This is hypertensive crisis of PIH. I'll give you the situation. A primary gravida with 37 weeks pregnancy with severe preeclampsia and twin gestation was admitted at a private hospital for elective LSCS. On the operating table, the patient was detected to have extensive crepitations in the lung fields and 85% oxygen saturation fell before induction of anesthesia. And the phone call came to me. I said, this is bad. This is pulmonary edema. This is the complication which we all dread and is the biggest killer in hypertension, severe preeclampsia. Surgery, I requested them to abandon it. They abandoned it. They gave 60 milligrams furosemide. The patient was intubated and transferred along with an anesthetist escort to a higher center. When the patient arrived at the tertiary hospital, she had 97% oxygen saturation because she was intubated, but there were still extensive crepitations. Thankfully, now she was fully dilated. Patient was shifted to ventilatory support. 40 milligrams furosemide was repeated, and a vaginal delivery was now to be done. They asked me, sir, vacuum or forceps? Pertinent question, because we still believe that for a vacuum it takes time. You have to create a chignon. No need. Latest evidence, 5 years old evidence suggests that no need. You can apply a vacuum and start a traction. The delivery took place, and within 6 hours, we repeated once, and the patient was given antihypertensives. We gave ventilatory support for 24 hours. Patient was slowly weaned off of respiratory support. So please, the lungs bear the brunt, which will make you bear the brunt in preeclampsia. There, because of that paradoxical situation. One side there is vasoconstriction, and you feel you can overload, that is bad. And I'm going to speak on reperfusion following vasoconstriction in Ambrish's program next month at Mysore. For us, this is a false crisis. This is a Russia-Ukraine war. We are not bothered in this, honestly. But still, how it is affecting us, you can see. You can see the price of petrol. You can see. False crisis for us. Such a false crisis I will introduce you to. Primary gravida, elective LSCS was done. A 4 kilogram baby, intraoperatively uneventful. Next day, suddenly she started looking pale. Her hemoglobin dropped from 12 to 8.1. She had cough, strong cough with expectoration and oliguria. She was a known case of bronchial asthma. Physician consult done, who started oxygen and did nebulization. 2 units of PCO were given because blood loss seemed to be there. She settled on day 3. We gave her iron sucrose to replenish her stores. This is not my case. This case came from Patna. On 5th day, ultrasound was suggestive of a possible broad ligament hematoma. What must have happened? Possibly violent cough. Don't always criticize yourself. Oh, I must have left a bleeder. Not necessary. Not necessary. Most of the times, doctors are very competent. What must have happened is a violent cough might have precipitated. Now, I told you in the first situation that you should palpate and go above. This is that broad ligament hematoma, which is deep inside. Should we intervene and evacuate? This is where a critical decision making comes in. And this is where the skill transfer program helps. Repeat HB on day 6 was 8.5. They waited for 1 day, and on day 6, it was 8.5, means it was not falling down. Patient had no complaints. She was ambulatory. And she said, please discharge me. I am fine. The question was, can we discharge her? Her vitals were stable, no fever, WBC count normal. On day 6, ultrasound was repeated. It showed the same hematoma, but her condition was same. Now what? So in crisis situation, near miss situations, sometimes you have to be lazy. Not every time you have to be overreacting. This was a case where be lazy, not doing anything, let her go home on the 6th day, come back after 7 days, and reassure her hemoglobin will actually rise, because her last RBC from the hematoma will go away on the 106th day. giving her that additional supply of hemoglobin. We come to the last part. I was given 40 minutes, actually 30 minutes. I am on 29 minutes and 18 seconds. I'll be finishing it by 35 minutes for sure. Dr. Hiremat,
Yeah, still
35
time is
minutes I
there.
will finish.
You can take time, sir.
This is the last case now, where near miss situation can have a long-term sequelae. I am taking an entire gamut. A long-term, how long? Very long. Let us see. Mrs. I, 26 years young. I should not call any lady old. Ladies are either young, very young, or very, very young. It is gentlemen who are old, like our Muralidhar Pai, or very old, like Hiremat sir, or very, very old, like me. Okay. So Mrs. I, 26 years young, G4P1, MTP3, was admitted with intermittent heavy vaginal bleeding for 2 weeks. This time she was nearly lost. She came from Guwahati. She had her last MTP just 7 months ago. 7 months ago. At that time, she bled very heavily, and she had to be subjected to bilateral internal iliac ligation for a suspected cervical pregnancy for severe bleeding during the MTP procedure. A real bad one. No histopathology records were available. It was the only paper was this. She remained asymptomatic for 2 cycles, and after this, she had irregular, profuse bouts of bleeding lasting for 10 to 15 days since last 5 months. You can imagine, near miss leaves its shadows very long. Clinically, she looked pale with hemoglobin of only 5 grams. Per abdomen finding was normal. Per speculum examination showed a normal cervix with no congestion, no erosion, no growth or ballooning of the portion. Per vaginal examination showed a normal sized firm uterus, and her biochemical profile was normal. There are brilliant people in Karnataka. Can anyone like to guess now? We have been given 5 minutes and we are about to finish. What must have happened here?
Choriocarcinoma?
Choriocarcinoma, but cervix was normal here.
Okay.
Here, you can see here, per specular exam showed a normal cervix, no congestion, and even uterus was normal. Per abdomen, per vagina, normal size firm uterus. Oh, sorry, I'll add. Biochemically normal means HCG was also normal.
Okay, okay.
Sir, could it be retained products?
So late, it can be seen on ultrasound. Ultrasound showed normal empty uterus.
AV fistula?
We are coming, excellent. I expected an answer in Karnataka. Empty normal uterus, no adnexal pathology. Cervix showed an irregular echogenicity within the matrix of 1.5 to 1.5 centimeters. And that is where the secret got revealed. What was the secret? A leash of vessels and vascularity suggesting an AV aneurysm, probably as a result of altered collateral circulation following bilateral internal iliac ligation had occurred. This should not stop any one of you from doing internal iliac. This is life-threatening and has saved thousands and thousands of lives. I have its video on my YouTube channel also. Thousands and thousands of lives have been saved. So please do, but be prepared, this can happen. Not in all. If there is a case, it will come in this discussion like this. So what was the conclusion here? The internal iliac ligation in this case has probably brought about an anatomical aberration, possibly iatrogenic in nature. Out of good faith, this can happen. So ladies and gentlemen, obstetrics is an uphill task. And people like me who love obstetrics, who still, I know, once again from Karnataka, I will be remembering him, I know he won't be here, but Dr. Prakash Mehta, many years before, decades before. He was the gentleman when everybody was telling, I don't do gynec, I don't do obstetrics, then levator leba elakinazi in a state of spasm, He don't do obstetrics, This was the gentleman who, when I said I do obstetrics, he walked up to me and said, sir, I love obstetrics. And another one was from my dear friend, she will not be here, of course, from Hyderabad, Dr. Evita Fernandez. We enjoy obstetrics. Yes, lots of gynec also, but we enjoy obstetrics. But we know, and probably because it is an uphill task like this, we enjoy. And yes, sometimes we become like this. It happens. And that is where it is very important not to play God. Don't try to be God. Don't try that everything I will do myself. Ask for help. Please ask for help. Your theoretical knowledge is excellent. I have also asked for help in spite of me and my wife. 25 years ago, this is a case 5 years before. So often we ask for help. Please come down, we need help. And I have a team now, which helps me and helps excellently. I help them, they help us. There is nothing wrong in asking, please help me. We require to be very alert. We require to be absolutely in command when we are handling obstetric emergencies. We require to be very well informed as to what is happening. Even today, I read for 2 hours every day in the morning, except when there is an endoscopic surgery and Dr. Vidya is not there, a master in endoscopic surgery, or B. Ramesh from your city. They are not there in Baroda. So I have to do those surgeries. I do it around 9:30 in the morning. Therefore, that is the time when I read a little less. But every day, still I read for 2 hours. Continue to be well informed and continue to be well read. Then and then, this is all for in the pursuit of academic excellence at the service of humanity and mankind.
Thank you so much. That was really brilliant. And
thank you very much for honoring me. So nice of you.
Sir, words fail us in expressing our appreciation and gratitude for taking us through this excellent session of telling us how we have to be observant, we have to be firm, and we should never hesitate to call for help.
Thank you, sir. Thank you so much. That was really brilliant. Every aspect.
We are not able to hear you properly.
Your wavelength, your broadway.
I think some problem with your
Put off your video and speak.
Yeah.
Put off your video and speak.
We have Dr. Chelappan from Bharuch who has joined us.
Yes,
sir.
Quite a good number of them have joined
popular.
from different places.
Your program is very popular.
Yes, sir. I think with your
Vidya, please put off your video and speak.
Vidya, there is a problem with your
network. Switch off your video and speak.
Can you do something?
I think she can switch off the video and speak, sir. Without video, it will improve. I request if there are any questions or any comments, I'm sure the session is open to the audience.
I would try to answer if I can.
Any questions in the chat box, Bharati?
No, sir. No, sir.
No, everybody has
all those 14 are appreciations.
Sir, there are no questions. You have made us so much information you have given. There is nothing to be asked again.
Okay.
You have cleared a lot.
Sir, but I really like that you have your message of we love obstetrics. Even I love obstetrics in spite of doing endoscopy. And I feel even as an IVF specialist, you should know obstetrics because the IVF pregnancies are really complicated. We land up with all sorts of complications. So your message today is so valuable, and I think everybody should learn obstetrics and love obstetrics.
I have one input to give. Dr. Deepa has asked a question.
Yes, sir.
There was some, Deepa, sorry, I will try to give the answer. This inflammatory response, see, after she is telling that there was one patient whose hemoglobin dropped, and then she collapsed after 6 hours, after 12 hours. Okay, she was 35 years,
Yes.
non-pregnant. Okay,
Oh.
non-pregnant, madam, then it's an open field. It will be very, very difficult. AUB patient, that will be very difficult because everything opens up now. And I may require lots of information. Please email me this case. Deepa, please email me this case. I promise you I will answer, and I may ask for more information. My email ID is drpankajDesai@gmail.com, and my website is drpankajDesai.com. Please give me your email. Please email me, and I will surely reply. This is my promise.
I think Dr. Deepa, that answers you. He will be talking to you or answering you. Dr. Pankaj Desai will answer you on email. Kindly forward the question to him. I request the Doyens and Dr. Amrish is here, Dr. Hiremat, Dr. Krishnananda Prabhu, Dwarknath. I request all of you to kindly put on your videos. And I think we all need to give a great applause to Dr. Pankaj Desai.
Concluding is there, Bharti.
Yes, no, sir. Vote of thanks is there. I now request
concluding remarks by chairperson.
By the chairperson.
Okay, thank you.
And Dr. M.J. Hiremat.
Vidya, you would like to say anything more?
Sir, superb.
Okay.
One word.
Right.
Superb, and thank you so much for accepting my invitation, sir. With the short notice, I know how busy you are, but thank you so much.
Did I have a choice?
No, sir.
Finish. Once you don't have a choice.
Okay, good evening, sir, once again.
And thanks for the kind
And
words of
what
calling
names
me
were coming?
excellent
Dr.
head of
Hiremat,
Yes.
Dr. Bharati, you, Amrish, what names were coming? How can did I have a choice? Dr. Malia is here, Krishnanand. After a long time I am seeing him. You think I had a choice? No, I didn't. You didn't give me any choice.
Dr. Pankaj Desai, sir, let me thank you for your nice the scientific program, which in fact you have concluded within 40 minutes only. And you have this topic we have particularly made today because it is the need of the hour. We thought that this is one which is very, very necessary for all our obstetricians. And sir, you have selected very nice cases, clinical cases, and you have given a lot of clinical tips also. In your enumeration, you have given some very good suggestion that recognize the situation. Unless you clinically recognize the situation, whatever amount of you have got any facility, that is not going to help. So clinical, then only other things will help you. Second most important message you have given us is a decision making. I think in obstetrics, this is one area where your decision making plays a very, very important. In many other, the decision making may not be that important, but we know in the labor room, it all your decision making which makes either to lose or gain the patient, and both mother and baby can be. Blood and blood products are necessary. Today we cannot practice obstetrics without a blood and blood products. Gone those days. See, in the last interaction with the DCs and the DHOs, they used to insist me that let us deliver the patients in the PHC and PHU. So I think PHC and PHU are not the places to deliver anybody.
Yes.
If you want to deliver anybody, it has to be a place where the facilities are available for cesarean section, where the facilities are available for anesthesia, where the facility is available for blood transfusion. Unless these important things, no delivery should be conducted. No delivery can be said safe unless the delivery is over and mother and child, including obstetricians, are okay. And establishment of HDU and ICU are very, very important. Even if you have got a small nursing home of 10 to 15 beds, please make a provision for 1 or 2 beds because it is very, very essential Lot of our friends have lost the court cases because they don't have a HDU and ICU. And patients, if they die in between while transporting, you will find it, as rightly said, sir, during his talk, that patient was intubated, patient was transported along with the anesthetist. I think that will save us in the court of law. And multidisciplinary management are very, very essential. Today, earlier, we never used to see the labor cases ending with medical problems, large number of medical problems. Today, we have made a platelet, the examination routine, because we are finding so many cases, we have got a low platelet count.
Yes.
It was never done in our learning phase. I think the clinical, and one word about inflammatory response. Sir, we are all very much convinced now how important is an inflammatory response. In COVID, most of the patients used to die because of inflammatory response before you do something. And same thing will happen in the obstetric cases also, with hypertension, diabetes, they all end up with inflammatory response. And near miss leaves its shadow very long. Sir has rightly told. Near miss leaves its shadow very long, and maternal death leads shadow lifelong. That is what I want to say, that we should not lose any mother. Mothers are the pillars of the house. Mother is the pillar of the family, and zero mortality should be the order of the day in future. I think to achieve this, we need a lot of teachers like Dr. Pankaj Desai, lot of learned people like Bandiwada, others, and all our Bharati and everybody. And learning should be a continuous phase, as rightly told, sir. I never pass a day without reading. Minimum reading has to be at least 2 hours a day, and then only you will be updated. And sir has given the skill transfer not only in the subject, he has given the skill transfer in many other things, how to be a good orator, how to give a good lecture, how to convince the people, and how to make an interesting lecture without any boring. Thank you very much, sir, for excellent lecture. We will be waiting for you for some other time in our KCOG program. And I'm very happy to tell you that our KCOG programs have become very, very popular. Many other state leaders are asking us how to form the KCOG, like Kerala, they asked me, Gujarat, they asked me in the conference in Indore. I think this is a very, very dedicated program. We have many programs in the association, but KCOG is oriented in a particular manner, like skill program. I feel it's an excellent program. And I think these are the new things which I have found last 1 year, and a very good response from the audience. Just we put up a WhatsApp flyer and we get at least 100 people for the program. Thank you very much, sir. Thank you very much once again.
Thank you, sir.
Yeah.
Thank you, Dr. G. Hemat, for those summing up the whole session so wonderfully. And I think at this moment, I would just make a small comment that if just in not only the shadow of a maternal mortality, we are just now in the shadow of a death of one of our own colleagues who had, if at all, Dr. Archana Sharma had just asked for help, had just called somebody
and had patience. She should have had patience.
Yes, I think she would be there to give the best obstetric help and services to many more women who needed her much. I think we pray for her departed soul. And I now request Dr. Manjula Patil, our Joint Secretary, to kindly deliver the vote of thanks.
Manjula.
Please unmute yourself, Manjula.
Is she there?
Yes, sir.
Yes, sir. It is indeed my privilege and honor to thank for today's one of the best, most awaited lecture of Dr. Pankaj Desai, sir. We are all privileged and we are all blessed to have you in the Kasoga platform. I don't have any words to express since you are such an authoritative person and your knowledge was so spontaneous, it was so flawless, and you are the epitome of knowledge and intelligence and humbleness. And it is a great message for all the youngsters to carry home messages with both the knowledge and the lifestyle. Your message of reading every day for 2 hours, it's really sending a message to all the youngsters and the practitioners that it is a must and should that we should update our knowledge to give the best for the patients as well as to teach the students. Thank you so much, sir, for gracing this occasion. And it is a big round of applause from all of us and from the bottom of our heart to be here and bless this beginning of the academic session of this year of Dr. Kasturi Donimath. And we are all so much grateful for you, sir. Thank you so much. Thank you so much. And I do thank Dr. Vidya Bhatt for giving such a wonderful person with the knowledge and the humility. And this would have been not possible without your support. And thank you, Vidya, for giving such a wonderful speaker and also a wonderful topic for this session. I also thank Dr. M.G. Hiremat sir, who is the patron of Kasoga, who is never a tireless person for giving the knowledge for all the postgraduates and all the juniors. And he is the backbone of Kasoga, being the head of the KCOG and Kasoga. He's been taking this so smoothly and flawlessly. And thank you, MG sir, for being there for us.
Thank you.
I thank Kasturi Donimath ma'am for giving such a wonderful beginning for this platform. And it is a great beginning and a great start for this academic session. I thank Sajjan sir, who is always on the wheels. And he's been there from A to Z without break and listening to you. And it's been so nice to have you, all the seniors, to encourage all the juniors. And I thank Dr. Hema ma'am, Dr. Murlidhar Pai sir, and all the seniors of KCOG and all the office bearers of Kasoga and all the EC members and Dr. Durgadas sir for being there and constantly supporting the juniors. And I also thank the MQR, who is always there for all the academic sessions.
Sun Pharma. Are you ready, Sun Pharma? Are you ready with your video? Because we are not able to visualize your video.
Yes, sir. Yes, sir.
Please play. Sir, Pankaj Desai, sir, just 5 minutes, sir.
Our academic partner, Sun Pharma, for being there for the academic sessions and encouraging these kind of programs. Thanks for being here, and we want to play your session.
Yeah, Nirmal Kumar, you can play the video.
Yes, sir. Yes, sir.
He is very keen that everybody should see this video.
And I
their new
thank
product.
Dr. Bharti ma'am for being there as a secretary and also the moderator of today's session, and who carried this session so well, flawlessly, and again always be there as a mentor for all the people who's always seeking the help and the need. And I thank all of you for being there and make this a great successful event.
You can start.
Priority. Maternal mortality is a rising concern worldwide, depriving millions of mothers of their rightful maternal joy. DPH is the leading cause of these maternal deaths in the world, especially in India. DPH accounts for 35% of worldwide maternal deaths and 38% in India. Current uterotonics drug for prevention of DPH is unstable at room temperature and requires cold storage. A break in cold chain or heat exposure reduces the drug's efficacy and causes drug degradation. To address these barriers, we are introducing, first time in India, Caritech for the prevention of DPH, an encouraging step that can help save thousands of maternal lives in our country. This room temperature stable carbetocin formulation is long-acting, available as a single dose administration, has a rapid onset of action. Carbetocin demonstrates lower chances of antidiuretic effect as compared to oxytocin, lower need for additional uterotonics as compared to oxytocin, significantly lower level of pain perceived after delivery by CS as compared to oxytocin. A single-use 1 ml of 100 microgram carbetocin is administered intravenously, intramuscularly after delivery of the infant and preferably before the delivery of the placenta. Carbetocin is recommended by various international bodies. WHO in 2019 has added room temperature stable carbetocin to the list of essential medicines for reproductive health. International consensus statement in 2019 states that as carbetocin eliminates the requirement for an infusion after the initial dose, it may become the preferred first-line drug rather than oxytocin. Maternity and neonatal clinical guidelines in 2020 states that for high-risk BPH cases, carbetocin may be considered for vaginal birth or elective or emergency CS birth under epidural or spinal anesthesia. SOGC in 2018 recommends carbetocin should be used instead of continuous oxytocin infusion in elective CS for prevention of BPH and to decrease the need for therapeutic uterotonics. Prescribe Keritech, novel room temperature stable, convenient uterotonics.
Now I request Dr. Pankaj Desai sir to say a few words. Dr. Pankaj Desai sir.
I have already spoken.
Yeah, just one more last message.
Only thing I can tell is, you started with Shubham Karoti Kalyanam.
Yeah,
that is the music which is played every day in morning in my house, in my home. Every day.
We have taken as a music of our KCOG.
Incense stick is lighted, that music automatically comes up. So thank you. I felt
Thank you very much, sir.
Thank you, sir.
Karnataka you address means my daughter is there.
Thank
Sir,
you.
please
Thank
come and
you.
settle down in Karnataka.
Come to Bangalore and settle. We have many other
Sir,
participants
become
like
Kasoga member, sir.
Yes, I will become
Professor Emeritus Kasoga.
I become an honorary member.
Yes,
Neha
sir.
Dega, Vijay Dhotra, again Dr. Sunita Lodaya, Dr. Impal, Dr. Bharti Kamoji, Kadambi, Challappan, Kurupai, Meghna, Rashmi, Meghna, Bharti, Kunjam. I think a lot of people have joined today. And
So
they
many have
made
left
this very
already.
successful, and they are all our the regular participants also. So once again, I would like to thank you, sir, on behalf of Kasoga and KCOG for making this day, Dr. Ambedkar Jayanti Day, as a wonderful day. Thank you.
Thank you very much, sir. Thank you.
Thank you,
Namaste
sir.
to all. Namaste to all.
Namaste, sir.
Good night, sir.
Good night.
Good night.
Thank you, sir. Thank you so much, sir.
Good night. Good night. Thank you, Nirmal.
Yeah, thanks, sir. Good night, sir.